Welcome to this in-depth explainer, where we're basically going to turn you into an expert on nasogastric tubes. Seriously, we'll cover everything from how to put one in to the kind of clinical judgment you'll need to make on the fly.
Okay, so here's our game plan. We're going to start with the absolute basics. Then we'll get into the different types of tubes, how to actually insert one, and, super important, how to make sure it's in the right place. We'll wrap up with daily management and some key tips to get you prepped for the NCLEX.
All right, first things first, let's build a really solid foundation here. We're going to start with the what and the why. What exactly is an NG tube, and why do we even use them in the first place?
So, at its most basic level, a gastric tube is just a plastic tube that gives us a direct line into a patient's stomach or small intestine. It sounds simple, right? But this little tube is a total game changer for patient care.
And this visual just lays it out perfectly. You can really see the journey that tube takes. It goes right through the nose, that's the naso part, and travels all the way down into the stomach, the gastric part. It's a clever way to get around the mouth and throat, letting us deliver food or pull stuff out.
Okay, so why would we put a patient through this? Well, it really boils down to three big reasons. We use them for feeding, when someone can't eat on their own. We use them to give medications, and we use them for something called decompression, which is basically just removing air and fluid from the stomach. Super helpful.
Okay, moving on. Now that we've got the why down, let's talk about the actual tools of the trade. You're going to see a few different types of these tubes, and it's definitely not a one-size-fits-all kind of deal.
So the two big ones you'll see most often are the Salem sump and the Dobhoff. The Salem sump, think of it as the workhorse. It's bigger, a little more rigid, and it's our go-to for suction. The Dobhoff, though, is the opposite. It's super flexible, smaller, and way more comfortable for patients who just need feedings.
Now, what makes the Salem sump so special is its design. It's actually a double lumen tube. So you've got the main, large tube for suctioning or whatever, and then you have this little blue pigtail. That pigtail is an air vent, and trust me, it's absolutely critical for making sure suctioning is done safely.
And this brings us to a super important memory anchor. You ready? Blue to the air. Say it, remember it, live by it. That blue pigtail has to stay open to the air. Why? Because it stops the main tube from just sucking onto the stomach lining and causing damage. So whatever you do, don't clamp it, don't put anything in it, just let it be.
Okay, now for the part you've all been waiting for, the insertion procedure itself. We're going to go step by step, from getting ready to final placement. This is a big deal, and it's all about being precise and keeping your patient safe.
Before you even think about picking up that tube, you've got some prep work to do. First, hand hygiene, always. Then, you have to explain the procedure to your client. They need to know what's happening. And finally, get them sitting up nice and tall, in high Fowler's position. This helps gravity do some of the work for you.
So how do you know how much tube to insert? Well, here's another key memory anchor for you. It's nose to ear to xiphoid. You literally measure from the tip of their nose, loop it to their earlobe, and then bring it down to the xiphoid process. Mark that length on the tube, and that's your target.
All right, now for the actual insertion. You're going to lubricate the tip really well. And then, as you start to advance the tube and it reaches the back of the throat, this is where your patient becomes your teammate. You'll have them tuck their chin to their chest and take small sips of water. Every time they swallow, you gently advance the tube.
So, let's pause for a second. Why is that chin-to-chest instruction so incredibly important? I mean, what's it actually doing? Well, anatomically, that simple movement helps the epiglottis cover the trachea, the windpipe. It basically closes the door to the lungs and opens up the path to the esophagus. It's a massive safety step.
Okay, major NCLEX safety alert right here. If, during insertion, your patient starts coughing their head off, looks like they can't breathe or can't speak, you stop. Immediately. No questions asked. That's a huge red flag that the tube is in their airway and you need to pull it back right away.
So, you got the tube in. Great. But you are not done. Not by a long shot. Confirming that the tube is actually in the stomach is, and I'm not exaggerating here, a matter of life and death. You absolutely cannot use that tube for anything until you know for sure where it is.
So how do we get that confirmation? Let me be crystal clear about this. The gold standard, the only 100% definitive way to confirm initial placement is an X-ray, period. End of story. No ifs, ands, or buts.
Now, you're probably thinking, wait,
but I've seen nurses pull back some stuff from the tube at the bedside. And you're right, we do aspirate gastric contents and check the pH. But, and this is crucial, that's just a preliminary check. It is never a substitute for that initial X-ray confirmation.
All right, so you've gotten that X-ray back, and it confirms perfect placement. Awesome! Now your job switches from insertion to management. And this part is all about ongoing care and keeping things safe day in and day out. So, what does that daily care look like? Well, you've got to flush the tube regularly to keep it from clogging. You're going to be keeping a close eye on intake and output, and don't forget oral and nasal care. That's super important to prevent skin breakdown. Oh, and remember our friend the Salem sump? You need to make sure that blue pigtail is always positioned above the stomach level to keep gastric contents from leaking out. And when it comes to giving feeds or meds through the tube, your new mantra is flush, flush, flush. Seriously, you're going to flush the tube with water before and after every single thing you put down it. It seems simple, but this is what will prevent nasty clogs from happening. Okay, let's put this all together now. How does this translate to your exams and, more importantly, to your clinical judgment as a nurse? This is where we take all this knowledge and see how it plays out in the real world and on the NCLEX.
Look, if you're cramming for an exam and can only remember a few things about NG tubes, make it these 4. 1. X-ray is the only way to confirm initial placement. 2. Blue to the air. 3. Chin to chest during insertion. And 4. If the patient shows any signs of respiratory distress, you stop. These are the absolute core safety principles, and I promise you they will come up.
All right, let's end with a quick clinical scenario. Picture this. Your patient has a brand new NG tube. Placement was confirmed by X-ray. Everything's great. But then, all of a sudden, they start coughing and get short of breath. What's your immediate move? What's going through your head? Well, you should be thinking that tube might have moved. It could be in the airway now. So your first action is to stop everything. Stop the feeding, stop the meds. Then you do a quick respiratory assessment and call the provider, like yesterday. That, my friends, is clinical judgment.